September 15th of 2024. It is time for another live IC support group meeting. I've been a support group leader for 30 years. This is my 30-year anniversary. And it's, hi, Gay. My purpose in doing these meetings is to educate you, is to inform you, it is to empower you, it is to comfort you, it is to give you the hug that you need, it is to give you the kick in the pants that you might need if you're being a wee bit passive and getting here, hold on, let me do that real quick. Getting in your way, getting in the way of your progress. So, for those of you who don't know me, I bring a lot of academic credentials to the discussion. So I have a degree in chemistry. I have a degree in drug development pharmacology, which is how do we make medications? Not pharmacy, it's pharmacology. Very different, working in a research lab. Turns out I didn't like that. I went into psychology instead. I love animals. You can't be an animal lover and work in pharmacology. So I switched over to psychology. I have a master's degree in psychology. I have a presidential fellowship in psychology. And then I got IC and pelvic pain, and I could not do my PhD. It was all part of the plan. But alas, injury got in the way. The IC Network website was, in fact, my doctoral dissertation proposal. I am very happy that all this time later, it is still rated the best in the world in 2 peer-reviewed studies. I take personal responsibility for it. I write the vast majority of the content. And it is my mission because I know what it's like to be at home suffering in silence. I know what it's like to get that blank look from a family member who doesn't understand. I know what it's like to have a doctor go, are you sure it's not all in your head? I know what it's like to be at the emergency room, sobbing your eyes out, begging for help, because I've done all that too. And what's so interesting is, pain is very, very isolating. And you're in this battle on your own. You're stuck in your bedroom on your own. And you're desperate for somebody to take up the fight for you. And yet, in the end, you have to be the fighter. You have to take charge. And, even though I was in grad school, I was really suffering with IBS because I'm in the widespread pain phenotype. So I had vulvodynia, I had IBS, I had migraines, I had IC, you name it, I had it all. And I kind of, how do I want to say this? I got beat up and worn out. And I developed a mentality that all was lost. Didn't have a lot of hope. Because I couldn't do what other people could do. And I couldn't. It was like the world was passing me by. You know how I'm, you know exactly what I'm saying. And then one day, I got woken up. And it was the day that changed my life. And it was the day that I was at the emergency room. Hi, Julie. And I had a doctor say, you will forever be a burden on your family. This is your life. You will always live with severe pain. Get used to it. And that was the moment when instead of being like this, I went, what? Like, what are you talking about? And I looked that doctor in the eyes, and I said, I will prove you wrong. How dare you say that to me? How dare you say that to me? And I went home and I started studying. And I proved them wrong because I've been pain-free now for many, many years. The vast majority of my pain conditions are gone now. Took a while. Turned out it wasn't a bladder disease. Turned out it was an injury to my central nervous system and an injury to my muscle. So once we walked away from doing bladder therapies for 20 years, which never got me where I needed to go, and we started doing the right thing for me, unique specifically, which was pelvic floor physical therapy combined with working on some nervous system stuff, I am symptom free, and I have been symptom free the great majority of the last 15 years. I still flare rarely, but I don't flare from my bladder wall. I flare from my pelvic floor because you can hurt your pelvic floor again. So what triggered all of my symptoms? Breaking my tailbone in 7th grade. That's what began the cascade. The absolute cascade of symptoms that by the time I was in my 30s, I was not doing well. We've come a long way since then. So why did I start this meeting late? Well, I was talking with Dr. Robert Eckenberg, who is not even arguably, in my opinion, the best pelvic pain doctor in the country, if not the world. Has a practice in Bethlehem, Pennsylvania. And his cause for the last 10 years or so has been, how do we educate the local gynecologists, the local urologists about all these new things that have happened, because good things have happened. We've got too many doctors who are still giving patients antibiotics. We've got too many doctors who are still telling patients they have an incurable bladder disease. And it's simply not true. So Dr. Eckenberg has released a brand new book. I just got my copy literally 10 minutes ago. And so I'm going to give you a review of that in our next meeting next week. But to have somebody of his caliber and his expertise recognize our needs and really work to try to educate other doctors along with patients about what causes this and what we can do to treat it is just everything. So our gratitude is endless to Dr. Eckenberg. Now, here's the sad news. He is retiring from clinical practice in December. He's still going to do telehealth with patients, but he's in his 80s now, and he is sharp as a point. For anybody who suggests that once you're over the age of 80, your life is over, My dad was sharp as a tack in his 80s and in his 90s. Dr. Eckenberg is fantastic. And now we have the benefit of decades of experience. And so he's still going to work with patients on the phone. He's just not going to see patients in clinic because he said he needs to slow down. I understand that. I need to slow down, and I'm 20 years younger than he is. Okay. So that's one really, really good thing is now we have his book. And again, I'll be reading it this week. And now, normally when I do these meetings, I do a little 30-minute intro, and then we go into taking your questions. We are live streaming right now on YouTube and Facebook. If I'm looking straight ahead, I'm looking at YouTube. If I'm looking over here, I'm looking at Facebook. No, backwards. If I'm looking straight ahead, it's Facebook. If I'm looking over here, it's YouTube. And hold on a sec. I got to fix the camera here for YouTube real quick. Is that better? It's a little low. Hold on. Yeah, it's good enough. Okay, now, the other thing that happened this week that I think is incredibly powerful is a new study that came out just literally on Thursday or Friday that talked about the damage that antibiotics do. So, and Dr. E and I were just talking about this. Again, we've got so many doctors giving patients antibiotics. I took a ton of antibiotics when I was younger after I broke my tailbone because they all thought it was a bladder infection, not a bladder infection. So the question then is, what are the risks of antibiotic use? Because there's always been a general assumption that, well, antibiotics kill bacteria. So they don't damage the human body. They just kill the bacteria. Well, now we have brand new research which shows that antibiotics in the bowel damage. Hold on. Well, we got a fire alert. Hold on. Okay, good. That's far away. Whew. Got to be on top of that. Fire season. Okay. So now we have research that shows exactly what antibiotics do in the bowel, and we are probably also in the bladder. You know what it does? It damages the cells that produce the mucosal barrier. Now remember the purpose of mucus in the bladder and the purpose of mucus in the bowel. It's protective. It's a barrier. It keeps the contents of your bowel out of the skin. It keeps the contents of your bladder out of your bladder wall. But what this research study showed, and they have the slides, and I mean, they've got the electron microscope proof of what's happening, is that it's actually breaking the mucosal barrier and it's allowing the bacteria to enter the tissue. Now, this is mind-blowing. I'll be doing an article on that. I have the study. It just came through. I haven't written anything on it on our website right now. Haven't done that yet because it just happened. Follow this up on the class on IC that was taught at the American Urology Association meeting last spring, where Dr. Ann Lenore Ackerman shared the biome research. So we know that the biome of an IC patient was first considered to be normal, less diverse, but normal. But when she looked at the biome based upon the phenotype of patients, what she found in patients who are bladder wall driven as compared to pelvic floor patients have completely normal biome. There's nothing wrong with their biome. Bladder wall patients did have an abundance of Lactobacillus iners. And Lactobacillus iners is a pathogenic lactobacillus. You know, good bacteria, you think Lactobacillus is generally considered good bacteria? Well, Lactobacillus is the first pathogenic. Iners is the first pathogenic Lactobacillus. That this type of Lactobacillus actually damages cells. This type of Lactobacillus does not control fungus. It doesn't behave like a normal Lactobacillus. Patients who are dominant in Lactobacillus iners who have bacterial vaginosis have a poor long-term outcome. Patients who are dominant in Lactobacillus crispatus have an excellent long-term outcome. So Lactobacillus iners is bad. It's bad. In fact, I worked with a patient this week. Her next generation testing found Lactobacillus iners, now that we know to look for that. So when she did her class, and the class on IC, and she was talking about this, she ended it by saying, please stop giving patients antibiotics when they have flares or when you are guessing they have a UTI, because there are unexpected consequences, sometimes long-term consequences to the antibiotic use. Consequence number one is when you kill the good Lactobacillus, the bad Lactobacillus dominates the biome, Lactobacillus iners. Concept number two now is antibiotics damage the mucosal layer itself. So I wrote an article, years ago. It was, why should you not self-medicate with antibiotics when you have a flare? We have to stop doing that. I did it. Honey, I'm you. Come on, I'm you. I've done all that back when we didn't know better. But now we know better. Now, some people say, but why do I feel better when I take an antibiotic? Because antibiotics have natural anti-inflammatory properties too. And ultimately, the appropriate time to take an antibiotic is when we have a test that proves you have a pathogenic infection. So if you have a urine culture that says, yes, you are dominant in a lot of E. coli, of course you have to use antibiotics to kill that, potentially. But if your urine culture comes back negative, maybe it's just a flare. And then for those patients who like, I don't care, I believe I have infection, I believe I have infection, these are all of my symptoms, then what I say to them is, okay, prove it, go have a next generation DNA urine test. If that comes back negative, you do not have infection. If that comes back positive, you have all the proof you need to do antibiotics. So I had a post-op infection from my mastectomy 2 months ago. An area of my incision about this big that never closed and was oozing pus. And I ended up in the emergency room, and it was not fun. And I did a 15-day course of Keflex. My gut had not been the same since I've done that. I mean, obviously I had to do it. I had a post-op infection. But I will tell you that I'm more crampy. My bowel movements are just a bit more crampy. And my goal now is to try to restore that biome. I'm doing that by taking a yogurt every day. I do a high protein yogurt. I'm trying to do natural sources of yogurt. And then occasionally I will take a probiotic, prebiotic pill also. So if you are taking antibiotics, Denise says she's been on a ton of antibiotics since May from UTI, now diverticulitis. You got to bring up your probiotics too, hun. I'm not saying antibiotics are bad. I'm just saying we have to use them in context. Hello, Nicole. Hello, Anne. Hi, Kayleen. Judy says, what are my thoughts on, hi, Julie. What are my thoughts on dry needling? Dry needling is important. If you've got trigger points in your pelvic floor and your pelvic floor is not responding to typical physical therapy because you've got tight, hard trigger points that aren't releasing, do the dry needling. Go for it. Absolutely go for it. Okay, now you guys on YouTube. I am not seeing. Okay. You guys on YouTube, you're being very, very quiet. Please feel free to ask questions. All right. Okay. So what else is happening? Third week IC Awareness Month. Oh, here, hold on a sec. Nicole says, Keflex is what they gave me when they thought I had a UTI. My stomach is still ruined as well. This was 8 months ago. I'm eating probiotic yogurt like Activia. The cramps are so bad. I'm not a fan of Activia, to be quite honest. I know that the few times that I tried it, because my elderly mother lived on that stuff, it just made me very gassy and uncomfortable. I do Oikos. Is it Oikos? High protein. I do a high protein yogurt. In fact, I had it this morning. I can look it up for you if you want to know. She said I was on back-to-back antibiotics for 4 weeks, 5 weeks during an unknown flare. Yeah. Valerie says, had the interstim and it worked for a while, but now it's not. Any ideas? Also, I've had awful pelvic pain. Valerie, when did you have your interstim put in? And what symptoms are you struggling with now? So interstim, for those who don't know, interstim is neuromodulation. So again, hi, Tammy. Like I talked about in our last meeting, or a little intro for the last meeting, IC treatment depends upon your phenotype. Okay, we're long past the days of giving somebody Elmiron, giving somebody an antidepressant, giving them the diet, and sending them on their way. We know that does not work for many, if not most patients. And the question is why? Well, because we're a very, very diverse patient population. Some of us are pelvic floor driven. A bladder treatment will not work for them. That's pointless. I'm living proof of that. Some patients have Hunner's lesions. Hunner's lesions are now connected to viral infections, Epstein-Barr, polyoma. So now we're testing new antiviral medications to work with Hunner's lesion patients, and we have that new Lactoferrin study. That Lactoferrin study that came out in August, which showed that Hunner's lesions improved dramatically using the simple over-the-counter supplement, Lactoferrin, which is the active ingredient in colostrum, has antibacterial, antifungal, antiviral properties. And so it makes sense that something like Lactoferrin would be helpful for somebody with Hunner's lesions. No side effects, nothing reported. I mean, there are many, many studies with different types of, different painful conditions, et cetera, and different chronic diseases, et cetera. Lactoferrin is found in all of our secretions in the human body. The lactoferrin you find on the market usually comes from cows. There's a lot of research behind it. And so I'm very, very excited about the lactoferrin study now, because now we have something that's over the counter that we can suggest that patients try before going to the more aggressive invasive therapies like cauterization, steroid injection, etc., supported by a valid, good research study. And that's what, again, what the American Urology Association says. The American Urology Association, in their guidelines, say, please start with the easy stuff before you go to the hard stuff. We want to do the less risky, less harmful things before you go to the more aggressive, more invasive, more challenging therapies that will have potentially more side effects and adverse events. Okay, Valerie said she had her interest in, so getting back to the point. So the question is, how would neuromodulation help a patient? So again, we've got phenotypes. Hunner's lesion, neuromod makes no sense. Estrogen atrophy, neuromodulation really makes no sense, in my opinion. Pelvic floor driven, there's some argument that neuromodulation can help restore some muscle tone. But would I put that ahead of physical therapy? Absolutely not. The segment that is the most responsive to neuromodulation are going to be patients who are really, really struggling with frequency urgency, where they've got a overactive bladder. In fact, neuromodulation is approved for overactive bladder and approved for incontinence. So there's a smallish window now for the typical InterStim patient and the IC patient population. We're no longer saying everybody is a candidate, because it just doesn't make sense from a phenotyping standpoint now. Okay, so you still have your frequency. You got up 9 times last night. Also bad during the day. Honey, when did that start? When did this flare start? Nicole says, my mother-in-law eats oikos. I can definitely try it myself. Looks good as well. Yeah, the peach flavor and the raspberry flavors and the strawberry flavors are awesome. Peach is my favorite. Okay, so Valerie, when did your flare start? Tammy says, every time I try to take probiotics, I have heartburn so bad I have to quit. So Tammy, what you're having is a histamine reaction to the antibiotics. And the person who figured that out was Gay Sandler, who is one of the older IC support groups. And she's one of my co-authors in our book, IC 101. It's not just a bladder disease. So an antihistamine might help. The question is it a probiotic pill or is it from a natural source? Can you eat yogurt? Can you eat kefir? Can you drink kefir? Does that provoke the same reaction as a pill? Vesna says, hello, Vesna. Nice to see you. Could you please give the protocol for the lactoferrin from the last time? Yeah. So what the IC study, so lactoferrin was found last year to be helpful in reducing recurrent UTI. And the protocol for lactoferrin was, and I have the study in a file here. Hold on. Is this it? Whoops. Yeah, here it is. Here it is. They did 5 a day for a week, 2 a day for a month, 1 a day for 3 months. And at the end of that period, 28 out of 31 patients had no flares, and 3 had 1 flare. And when they looked at the markers for inflammation, specifically interleukins, they had decreased. But the most profound result was when they looked at the bladder after lactoferrin therapy, because the redness had disappeared, and so did Hunner's lesions. The Hunner's lesions virtually disappeared. They were dramatically improved after this easy 3-month course of lactoferrin. Now, it is a smallish study, only 31 patients. They want to do a larger study. I've reached out to them. They've reached out to me. And we're going to see what we can do to try to find a research center here in the United States who might do more research on that. But, you know, as I said to Dr. Eckenberg, the harsh reality here is that medical care is expensive. And many patients simply cannot afford more aggressive treatment for a Hunner's lesion. They can't afford to have a hydrodistension. They cannot afford to have cauterization. They can't afford to even have a simple steroid shot. And so they're stuck suffering with an open lesion. If there is even a remote chance that this simple over-the-counter supplement, lactoferrin, can help reduce that, then in my opinion, that's a valid thing to try. And the AUA guidelines say explore the supplements, but they don't give brand names. They don't give brand names. They just say explore the supplements as part of your self-help, and let's see if some of the supplements might help us. So now lactoferrin's right in there. I'm hoping to bring in the first lactoferrin I brought into the IC Network shop. I only got 12 bottles, so it was very expensive because it was very, very high quality. $75 per bottle. Sorry, but it was what I could find. I've now found a new company that was from Australia. I found a new company, and I've asked if I can resell their lactoferrin at half the price. So cross your fingers. Hopefully I'll find out this week. Tammy says, I have allergies to milk, so I eat almond yogurt. Okay. So if you can eat the almond yogurt or eat coconut milk yogurt, and you don't have nausea from it, then that's where you need to get your probiotics, hon. It's just, when you take a probiotic or a prebiotic pill, it's just too strong for you specifically. So just go with the natural approach. Denise says, sometimes when my vulva burns, I feel it in my bladder. I do use hormone cream. Okay. Okay. Well, again, if you have estrogen atrophy on your vulva, if you have pain on the outside, if your urine feels hot, like it's burning you, that is a classic sign of genitourinary syndrome of menopause. That means skin is getting dry from the lots of estrogen. So make sure you continue to use that hormone cream, but you might benefit from vulva balm. So vulva balm is about as close to the consistency of natural mucus as you're going to find. This is an oil. It is a very, very light oil. It's an organic avocado and olive oil, extremely light. You don't soothe the vulva with water. You soothe the vulva with something which pushes away water. We have to push away the urine. And so it takes an oil, something that's hydrophobic, to push it away. So you can see it here. Super, super light. Smells great. This is a great thing to use on your vulva. If you're struggling with dryness or that sensation like your urine is very, very hot. Valerie says, had a foot procedure, was on a knee scooter for 6 weeks, then got nerve problem in the foot, stress at work. Girl, I hear you. I hear you. I have got, because of my mastectomy, I've been sitting around a lot, and which has now traumatized my pelvic floor. So I have pain by my left ischial tuberosity, also known as your sit bone, and then my right thigh is just ridiculously tight right now. Like I walk and I go, ow. I have to do this massive stretching. Getting older sucks, and recovering from surgery sucks. Rebecca said, I use estrogen cream. I've been dizzy a lot at work. Now on progesterone also. I'm still dizzy, probably from the hormone changes at the end of perimenopause. So, Rebecca, what I had for a couple of years, so maybe this is what you're having. So, like, I didn't have a big, long, hot flash. What I had was a quick wave of nausea and then a quick wave of dizziness, like nausea for a minute or 30 seconds, dizziness for a minute or 30 seconds. And then I would have this like 2-minute burst of heat in my skin. And it was very specific. Wave of nausea, wave of dizziness, and then this little mini burst of heat. Now, having one of those a day would have been fine. The problem is I was having like 10 or 20 of those a day. And that lasted, I don't know, how long did that last? A couple of years. And some days were worse and some days were better. And eventually it went away. So I'm wondering if that's the way you're experiencing your dizziness. Vesna says, can IC Network deliver lactoferrin to Great Britain? Philip lives in Great Britain. No, we still can't. But I have our Great Britain Amazon page, and I will add lactoferrin to that. So I will go to the Amazon UK page for the IC Network, and I'll find a lactoferrin there that you can order. We are just continue to be very, very greatly challenged shipping any supplements to Europe. It's just virtually impossible. The only other thing you can do is if you have a friend here in the United States, we can ship it to them, and then they can send it to you. But I can't send it to you directly because you have to be registered in every country that you send it to. But they don't want them anyway. The European Union automatically denies supplements like this from the United States. But if we were to try to do it again, if they were approved, I would have to have a registered agent in every single country on retainer. We're talking lots of money there. I just don't have that money. I don't have that money. I mean, the US economy is doing incredibly well. The problem is it's doing incredibly well for the super rich. But for those of us who are small business owners, there's a definite squeeze as these bigger companies are just gouging everybody. I mean, you just wouldn't believe what I see at the wholesale end. Very frustrating. Vesna says, we have relatives in Australia. He will bring it to us, but we shall not see Philip before Christmas. Okay, well, we can definitely ship to Australia. Definitely ship to Australia. Rebecca says, mine is yes, a lot during the day. I'm a barber and I stand. Is there anything that I can do to help it? Well, Rebecca, this is the context where you would talk with your doctor and ask and you might benefit from a very short-term dose of oral estrogen, like for 6 months, just to try to get you through the hardest part. You'll have to talk. I mean, that's why hormone replacement therapy is so important. It's for patients who have very, very severe menopause effects, that it can modulate that so that you can at least function. The challenge, of course, is the longer you take oral estrogen, the greater the risk of the cancers associated with oral estrogen. Speaking as a breast cancer patient myself, they got it all. My lymph nodes are clear, but you're forever changed. You're forever changed when you're told you have a cancer like this. I had like I've been doing really well. Recovering from anything is a physical, mental, and emotional challenge. And so like I'd had a good 10 days or so. And then yesterday I just had to get out of the house. So I was just out shopping, and I went to did a little series of art exhibits in people's homes, and I went there and I bought a couple things, and I had like this really great day. And then I got home and I just burst into tears. And I cried for about an hour. And somebody said to me, because I'm very open about what I've gone through, somebody said to me that cancer is unexpressed tears. Her grandmother told her that cancer is unexpressed tears. In other words, the association of stress and how stress and grief contributes to cancer, which absolutely is proven in research. And I don't know, man, I just walked into the house last night and I just lost it for about an hour. I just think, we have to really make sure that we respect the emotional side of dealing with pain and the emotional side of dealing with new diagnoses. And rather than letting it sit in our bodies and letting it stew, we have to get it out. And if crying gets it out, power to you. If journaling gets it out, power to you. We have to release these emotions and find that calm, happy place. And that's hard right now. Definitely hard right now. Guys, I need to go to the bathroom. I'll be right back. Let's take a quick bio, okay? Because I drank a big thing of water before I started this meeting, and now I'm regretting it. I'll be right back. All right, all right, all right. All righty then. Want to take a moment and thank Prelief, DSC Healthcare Solutions, the makers of Prelief, for sponsoring this live support group meeting. They have been sponsoring the IC community for many, 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 many years, decades, as a matter of fact. The first manufacturer, AK Pharma, was the first sponsor of the IC network. I worked with him for 25 years. And then he finally retired and sold his company to DSC Healthcare Solutions, and now we're working with them. Prelief is a supplement that will help you eat acidic foods so that the acid does not bother your bladder so much. So, here, hold on a second. So if you haven't seen a bottle of Prelief, here it is. It is also now classified as a medical food for the treatment of IC flare. What's it? IC flares? Anyway, it's classified now as a medical food. 2 capsules will release 95% of the acid in a cup of coffee. So if you're looking for something that will help you eat a more balanced diet and enjoy some of those foods, especially now that the cool weather is coming, thank goodness. I love the fall. I absolutely love the fall. I love pumpkin soup. I love butternut squash soup. I love making stew. I love warm comfort foods like cinnamon rolls and things like that the fall brings. And this can help you enjoy some of those more risky foods. Now, what's so interesting is, so I followed the diet for 25 years. 25 years. And then last year, actually more than that, 28 years. Last year I got COVID and I was coughing so violently. It was as my mother was dying in the hospital, and I was coughing. I had to run out of her hospital room. It's the last, no, it wasn't quite the last time, but no, it was the last time I saw her alive. God bless America. We all got COVID at the hospital, and so I was wearing a mask. I went in and saw her, and I started coughing, and I had to run out after like 5 minutes. I was coughing so violently from COVID. And as I'm driving home, the only thing that went through my brain was to stop this cough was hot lemonade and honey. I realized I hadn't had lemonade in 28 years. And I was so desperate because I wanted to get back to the hospital and see my mom. I stopped at the store. I bought lemonade. I bought honey. I went home. I heated up a cup, put honey in it, and I drank it. And you know what? I didn't flare. I was gobsmacked. I was gobsmacked. I had not had citrus in decades. I drink lemonade every day now. I'm drinking it right now. I've got some, granted, I dilute it quite a bit, but I drink lemonade every day. I have not flared from it. I've also been eating a ton of tomatoes. Haven't flared from it. Why? Because I got the right therapy. Yes, I had bladder wall symptoms. Undeniably, I had bladder wall symptoms. I was food sensitive for many years. But the reason why I was food sensitive was because my muscles were so tight. It was restricting blood flow to my bladder. My bladder couldn't heal. We call this ischemia. And the great majority of IC patients who have tight pelvic floor muscles are in a state of ischemia or ischemia. If your bladder is supposed to get 28 units or 24 units of blood a day and it's only getting 10, do you have a healthy bladder wall? No, of course not. The bladder cannot be healthy if it's deprived of vital nutrition and oxygen. So the bladder wall starts to break down. But our therapeutic priority for the pelvic pain patient is physical therapy. Why? Because we have to restore blood supply. We've got to get these muscles relaxed and released so we get good blood flowing to the bladder again. That's what we need. We need good blood flowing to the bladder. And so I realize now in hindsight, because I've been doing physical therapy for a good 8 or 9 years, my bladder wall has healed. My mucosal layer has healed completely, which is why I can drink. I mean, it looks like water, but there's a little lemonade in it. All right. I love all the people. So here, hold on a sec. Rebecca says, thank you, Jill. Valerie says, you're so brave and courageous. I know it must be hard. It has been very, very hard. Sylvian says, you're so inspiring and kind. Thank you, hon. Thank you. Jenny says she loves Prelief. Gay says, I use Prelief. Sylvian says, Prelief is a big help for me. Valerie says, what do you use Prelief for? You use Prelief before you eat a meal that is going to have something acidic in it, something that you would flare from. So like spaghetti or like chili, or if you're going to drink a hot coffee or a hot tea, or especially a hot green tea. So Prelief doesn't act on the bladder itself. Prelief just reduces the acid level in your urine. And so it makes your urine less irritating. Prelief has been out. I think Alan Kligerman invented it a couple years before I started the IC Network. He's the guy who invented Lactate and Beano. Well, he also invented Prelief. Really, really nice guy. And he's still alive, and he's in his late 90s, and he's all there. I'm a huge fan of Alan Kligerman. Huge, huge fan. So it's a vital option if you want to try to eat some riskier foods. Nicole says, I haven't been here longer than I would have liked. And I'd like to say again, Jill, thank you for everything you do, for sitting here with us whenever you can each Sunday and helping us who are still suffering. It means a lot to us. You are such a reassuring voice to hear when some of our minds are spiraling. Thank you, hon. That's like one of the nicest things you can say to me. My approach to IC is a lot of it has changed dramatically. When I started the IC Network, I was focusing on educating the masses. We've worked with millions of patients in the last 30 years. Today, I'm focusing on individual patients. I realize I can't do it all, that there are more voices out there, which is a blessing, because back in those days, there was only one person on the internet, and it was me. My team was a solo voice for a good 15, 17 years before Facebook got started. But now we have more support groups that are kind of scattered around, and that's a relief, because I know I can't do it all. And if I can help one person a day, that's a good day for me. I'm reprioritizing a lot of stuff. Like, I'm very, very close to shutting down our forum, our support forum now, because people don't use support forums anymore. We don't see a lot of activity on support forums. And across the wide spectrum of forums, not just the IC ones. Most of the forums out there have shut down. I'm keeping ours up because I don't know what to do with it right now. I mean, we could write 10 books based upon patient stories in the forum alone. So I'm probably going to make a decision by the end of the year about that. It's got to be able to support itself, and it's not supporting itself right now. I will tell you, our IC Optimist magazine is now at the printer. So because of my cancer surgery, I could not do our summer magazine. So I combined our summer fall magazine into a massive 40-page magazine, which is big for us. And we've got articles, here, let's see. Can I print out the cover? Here, hold on. It's in production right now. If I had a copy of it, I would show it to you, but I don't have a copy of it yet. All right. There it is. Yeah, let me just print out this cover and I can at least show that to you. So it will be on your, for those of you who are members of the IC network, you'll be able to download it from your member page in the next couple of days. I will definitely get it up. And then once we have it back from the printer, I will have it for sale in the IC network shop. And this is how we raise money for, doing meetings like this. And honestly, this is where I do my best work, is in our magazine. So here's the cover. One of the things that I really like to focus on and highlight are the more unusual causes of bladder symptoms. And so in this magazine, we have the story of a woman who whose bladder symptoms were caused by a nickel allergy. So she had had a joint replacement. And, or no, it wasn't a joint replacement. She had foot surgery and she had a hammer toe. So to anchor the hammer toe, to get it to stop bending down, they had to put wire through it. And it was a wire made of nickel. And literally within days of them doing this, she started having bladder symptoms. But then a couple weeks later, they pulled it out and their symptoms went away. Well, then she had to have another surgery where they put in another foot surgery where they had to put in a plate that was supposed to be titanium. But the exact same thing happened. The exact same thing happened. Just days after she had it, all of her bladder symptoms started again. And so she finally, it was just very, very frustrating for her. Once it all healed, she just demanded that they take it off, take this out because the bone had healed. And when they took it out, her symptoms went away slowly but steadily. They went away. And when they analyzed the implant, it had nickel in it. So this is the first time that we have traced bladder symptoms to nickel. Now, we have also traced in a small group of patients bladder symptoms to gluten. If you happen to be gluten intolerant, that can cause urinary symptoms. And then I think one of the more interesting ones that we've seen is tuberculosis. So if your symptoms began after traveling, we have to consider the concept of you being infected with rarer and more unusual infections in your travel, especially if you travel to the Middle East, Asia, and Africa. So tuberculosis, which of course we know is a very contagious disease of the lungs, it turns out in like 35% of the people who get tuberculosis, it moves throughout their body, including to the urinary tract, where you get something called bladder tuberculosis. Now, what are the symptoms of bladder tuberculosis? Well, you know them: frequency, urgency, pressure, pain. The cool thing here is that it is completely curable with the correct antibiotic. So, whenever I work with patients and we do our coaching, I'm always asking, is there any event that you associate with the onset of your symptoms, specifically traveling? I was working with a patient a couple months ago who her symptoms started after she spent some time in Central America. And they were doing a lot of water sports. And they were doing a lot of water sports in really murky brown water. And it turned out that she had, and her IC symptoms began after that trip. Well, it turned out she had a parasite, and that's where her bladder symptoms started. So, you are an anatomical mystery to be solved, and I'm not prepared at all to give up on anybody. If you're not responding to typical therapies, we're going to try to figure out why, and we're going to look at some of these rarer and more unusual causes of urinary symptoms, because I want you to get better. All right, now September is IC Awareness Month. And we have been posting daily facts on our Facebook page, on all of our social media channels. Although I think I'm 2 days behind right now from the weekend, but I will do it tonight. I hope that you're helping us by spreading that word, because our goal here is to try to find those patients who are suffering in silence, find those patients who were told they had an incurable bladder disease, find those patients who have not responded to bladder therapies, and letting them know, there might be an important reason why you're not getting better. Let's see if we can reconsider your diagnosis and do a proper phenotyping to make sure we know what we're treating. I mean, I'm just heartbroken for those patients who have been told that it's all in their heads. Absolutely heartbroken. Whoops. Okay, hold on. Where's my mouse? So we spent a lot of time last year updating all of our daily facts with brand new graphics, and they're really, really, really good graphics. So let's look at the awareness facts for this week. Okay, so today is the 15th, so let's start with the 15th. IC patients may be eligible for disability insurance. That's very true. You might be eligible for disability benefits. I got state disability for a year because I couldn't work. There's no way I couldn't sit in a car without crying my eyes out. The important thing you have to understand about disability insurance is that there are multiple types of disability insurance. There's private insurance, there's insurance from your employer, there is state disability insurance, and there's federal Social Security disability benefits. They're very, very different. State disability benefits are about getting you back to work. The maximum you can get state disability is a year. You can work with state disability. You just report your income and they reduce your check based upon how much money you're making. But the entire goal of state disability is to get you back to work. So this is what people use when they break a leg. This is what people use when they have babies. This is what people use when they suddenly have to have a mastectomy. Right? It's to get you through a difficult point in your life and get you back. Federal disability benefits through Social Security are very, very different. These are benefits that are given to you under the assumption that you will not be able to work again. These are long-term benefits. And there are two types of long-term benefits. One is called SSI, Supplemental Security Income. SSI is given to patients who have not worked or given to patients who have profound disabilities when they're very young, like being blind. Supplemental Security Income, SSI benefits are paltry. They're minimal. I mean, they're not even minimal. You will be at the poverty line or below it if you're living on SSI. SSA disability benefits are the benefits that you are entitled to if you have a work history. These are benefits that you pay into. It is an insurance plan. So this is the insurance that you get for your retirement benefits. To be approved, another fire update. To be approved, you generally have to work for 10 years. It's a little bit different if you're in your 20s. There's an income test that they can use, but you're not entitled to Social Security disability benefits Oh, it's growing. No, 30 acres. They've released half of the plains. It's about 15 miles to my east. Okay. You know, with fire season, we got to be on top of all these fires. They go way too fast. Social Security is not an entitlement. It is something we have all paid into. And it is infuriating to see certain politicians suggest canceling Social Security. If they want to do that, I want my money back because I paid into it. So as you ponder the election, you need to, and you're thinking you're going to live on your Social Security benefits, be prepared for the fact that there is one political party that has very openly said they want to get rid of this entitlement, but it's not an entitlement. We paid into it. Okay, let's go to our next one. Daily Facts 16. IC patients often feel their worst symptoms at night. Sleep deprivation is absolutely real. So why do you feel your IC symptoms at night? Because you don't have the distractions that you have during the day. And so it's very, very common for you to have a flare at night based upon something you've eaten during that day. You know, some people ask, how quickly will you feel a flare? Well, if you're diet sensitive and you've got a damaged bladder wall from a Hunner's lesion, then you foolishly drink a beer or something or wine, you're going to feel the effect of the alcohol and that acid in your bladder as soon as it reaches your bladder. You're going to feel that flare within 30 to 45 minutes. But that's extreme. For some people, the flares they're much minor, and you might not feel it that quickly. It could be from you eating some very mild irritants during the day, and you don't feel it right away, but you do feel it as soon as you go to bed and you're laying in bed, you're trying to fall asleep. That's when you feel the need to pee all the time. Annoying. Am I right? Am I right? Hi, Renee. Sylviane says, Lori says, how do you take Prelief in the morning? You take it before a meal. It's not morning and evening because it acts on food. So you take Prelief in the morning. In the morning at breakfast or at lunch or dinner. Renee says, glad you didn't cut. I'm getting closer. My hair is falling out like mad from the anesthesia. So I've lost a lot of hair. All right, let's go to our next one. IC Awareness Daily Fact number 17. Millions of men struggle with tight pelvic floor muscles and have been misdiagnosed with prostatitis or IC. Very, very true. Now we believe that 85% of IC patients are in the pelvic floor category, the neuromuscular category, and I believe that men, it's actually up in the 90 to 95%. So for those men who complain of frequency, urgency, pressure, pain, and their infections come back, the challenge that men face is there's an immediate assumption that they have a prostate infection. They are immediately given antibiotics. And getting that doctor to look beyond the prostate and look at the bladder itself and or to consider the muscles has been very, very difficult. That's exactly why we do IC Awareness Month, to get this info out. IC Awareness Month Daily Fact number 18. Physical and emotional stress can trigger a flare. Anxiety management is essential. So why does stress trigger a flare? Because when you're under stress, your heart rate is increased, your blood pressure is increased, and your muscles are tightened. Can we say long-term pelvic floor dysfunction? And then stress, you know, if I remember correctly, increases neurosensitivity. More importantly, pain that is accompanied by stress, the way the brain processes pain messages is it looks at context and it looks at how you're feeling overall when it's trying to interpret this new pain message. Is this vital pain or is this minor pain? So one of the ways that the brain does that is by looking at your state of mind. So if pain is accompanied by tears, if pain is accompanied by deep worry and stress, your brain goes, uh-oh, maybe your life is at stake. Your brain will then intensify that pain because it's trying to get you to take action. It's fascinating the way the brain processes pain. And I have a cute little book that explains it if you're interested. Pain that is accompanied by laughter is minimized by the brain because you're laughing. Therefore, since you're laughing, clearly your life is not at stake. Therefore, this is not important pain. Therefore, the brain goes, it's not as big a deal as we think it is. How many times, this has happened to me multiple times, where you just feel terrible and you're trying to decide, should you call the doctor? So then you call the doctor or you go to urgent care, even you go to the emergency room. And the closer you get, the worse you feel. It's like, oh my God, this is awful. Like, I'm so sick right now. I don't know what's wrong. And then you get there and then you see the doctor. And then the doctor has a really easy explanation. It's like, Jill, you sprained your ankle. Oh, really? Oh, that's not a big deal. And then all of a sudden, they wrap your ankle and then you get out to your car and you're in your car driving home going, oh God, I feel so much better. That's why one of the rules that I have, although I'm not so good at it now, but I learned this early on, is if I was worried about anything medical, it's just like, get your ass to the doctor. Just go. Don't agonize over it. Just go and get them checked out. 9 times out of 10, it's perfectly explainable and nothing to worry about. So rather than worry for weeks or months about something, let's just get rid of the worry. Let's just get rid of the stress. That's been the way I've approached medicine for the last 40 years. But I will say that I'm sick of the doctor. Like, I need to go get my thyroid tested. I haven't even emailed the doctor yet to order the test because I've had too much this year. I just want to just say, leave me alone. I don't want to see any of you for at least 6 months. I'm done. I'm freaking done with you. And so I think that's a fairly natural response too. But please learn from my lesson. Make sure you're getting your mammograms. You've got to get your mammograms. Like 2 weeks ago, I was talking to somebody whose friend she could feel a lump the size of a walnut in her breast. And she had not gone to the doctor in like a year and a half since finding it. She was too afraid of the diagnosis. The longer you wait, the greater the risk. So just go. Renee says, when was my thyroid tested last? Oh, just a couple months ago. We have been I've had a life lesson in stress in the last 2 years, caring for my elderly parents. And I developed minor high blood pressure, caring for them. And I will tell you, it still stuns me. I've always considered myself to be in total control of this stuff. And all of a sudden, I have what? Like, what? My blood pressure is 150 over 100. And it all came down to 2 things. Number one, I was arguing with my 100-year-old father about driving. He wanted to drive, and we got into some vicious arguments about that. And trying to keep them alive during COVID and during fire season. And my stress was out of control. So We were just trying different high blood pressure meds, and we tried hydrochlorothiazide. It didn't do that much. I mean, I was still in the like 140s over high 80s. And then we switched to amlodipine, and amlodipine was great. I was down to 118 over 78, but it completely turned my thyroid off in a month. And that was like last May. And so it took a month to correct it. I just got off the amlodipine and I went on losartan. So my blood pressure now is in the 130 over 77 area. And I'm like, good enough for me. Good enough for me. I'm just like sick of it. Just leave me alone. I'm done with you all. I do not want to drive to the hospital. I do not want to walk into the hospital. I've had 2 surgeries in 6 months. I'm done. Okay. Renee says, on borderline hyperthyroid function, pain makes it go up. I believe it. I believe it. Anne says, what can I do for itchiness outside the vagina? That itchiness in all likelihood is coming from very, very dry skin. And so number one, you've got to get your skin healthy using that topical estrogen cream to give that skin what it needs to produce mucus. That's number one. Number two, doing something like vulva balm, which acts to protect that skin so that the nerves aren't triggered so much. A vulva balm is to die for good. Patients love it. And then be aware of the fact you really do need to work with your gynecologist. There is a condition called lichen sclerosus. Lichen sclerosus is fascinating because the name of it's deceptive, because lichen is kind of a plant that grows on trees. So it's like the assumption is if you have lichen sclerosus, you've got some sort of infection. Turns out that's not the case. So it's just a poor choice for a name. Lichen sclerosus is like really, really, really severe neuroinflammation combined, I think, with some ischemia. And so what happens is that the vulva turns white. The tissues get very pale. There's very, very poor blood supply. So if you have lichen sclerosus, the therapy for that itchiness is going to be a strong steroid called clobetasol. And it's this treatment of choice for lichen sclerosus is to calm that inflammation happening in that tissue with clobetasol. So it's very, very important, Anne, that you let them look at your vulva just to make sure you don't have that going on. It's either estrogen atrophy or lichen sclerosus, or maybe even some bacterial vaginosis or yeast. So go to that doctor and get a swab and have them check it. All right. Renee says, hypothyroid, hope you're okay. Mine runs that and less stressor and pain. It's crazy. All right. IC awareness daily fact number 22. Are treatments too expensive? Most IC meds are covered by drug assistance programs. So this is kind of an industry secret called a patient assistance program or a drug assistance program. And virtually every medication on the market has one that the manufacturer offers. The problem is they don't tell you about it. So if, for example, you were taking Elmiron, which could be very, very expensive, if you went to their website, somewhere on that website in very small print, there would probably be a reference to a patient assistance program or drug assistance program. And then you fill out an application, and they have to validate that you're very low income. If you're low income, they will then give it to you for free. So a lot of medications that we have used do have drug assistance programs or patient assistance programs. what I'm trying to do is I'm trying to, again, I've been working with some profoundly impoverished patients recently. Like literally, they don't have $10 to buy food, and wanting to find something that would help them that would be free. And that patient assistance program is a great way to do that, to get some of these traditional meds. I also have a friend who lived in Colorado. She was in Colorado and now she's in Minnesota. And let me tell you, that woman found the most amazing free medical programs. In hospital, she was able to get hospitals to pay for surgery. She was able to get medical foundations to pay doctors' fees. There are a lot of programs out there if you can be a really good detective and look for them. Don't assume there's nothing. You just start calling people and asking, is there a medical assistance program? Do you help patients who are low income? And then another thing of looking at, and like I was thinking this morning, I want to start a foundation. I want to start a foundation to help these patients where we could send them money to pay for their power bill, money to buy meds. Like literally, I was just thinking that this morning as I was washing my hair. We need that so badly. I'd like to be able to pay the tuition of students going back to college. Wouldn't that be incredible? That's like, it's on my list. If I ever won the lottery, believe me, I have every intention of doing that. We just don't have the money for it right now. And I give a ton of stuff away for free to these patients. But, I'm just one person. And I don't have a pension. So once I retire from the IC network, I'm going to be living on Social Security if we have Social Security and whatever I can save. And so I'm working hard to save as much as I can so that I can live with some dignity when I'm 80 and 90 years old. Kind of scary, especially if you're single and you don't have kids. Yikes. All right, guys. So we have been going now for an hour and a half. I'm here as long as you have questions for me. And so please feel free to ask your questions if you have them. Renee says, could that be done by canvassing doctors and hospitals, county commissioners? Yes, but almost every hospital and or every county has a medical association. So like when we did our first IC conference, I got it all paid for. Everything was paid for. And so it was free for everybody. And so what I did is I found the medical foundation for my county. And what a lot of people don't know is that hospitals and medical foundations, their job often is to do something called grand rounds or to create CME programs for doctors, continuing education units for doctors. Doctors and nurses and healthcare staff are required every year to take courses and to meet this level. I don't know how many it is. It might be 20 or 30 a year, showing that they're always working and building their knowledge. So the employee who is responsible for creating these CEU courses or these grand round courses, they're desperate for topics. Absolutely. They're like, you got an idea? Please hit me. Please give me something. I need something that I can do that's new and different. And so I called the county foundation and said, what can you do? And they said, well, can we get some speakers to do a course? And then I called the hospital. It was Kaiser Hospital, and talked with their CEU person. And I said, so there any chance you need a course? Is there anything I can do to entice you to do a course on bladder pain? They went, oh, yes, please. Give us something. So I had the county foundation pay for it. The hospital took it. They paid for the facility. We trained, I don't know, like 48 doctors, flew in the top IC doctors in the country. The pharmaceutical companies paid for that. And in the end result, we had a fantastic 2-day event. The first day with doctor education, the second day with patient education, and it was free. So where there's a will, there's a way. I will tell you, I did piss off people with that conference. That was when I was part of the ICA. Our group was part of the ICA, and they wanted me to charge. And they wanted that money to go back to them. I said, no. They went, but it's fundraising. I went like, no, we're not using this to make money. We're using this to educate others. So that was back in 1994, if I remember correctly. So where there's a will, there's a way. And we really have to think about, what do we want to do, in 2025 now? What do we want to do that's new and different? That's where it gets a little frustrating, because everything's changed. So much has changed, because patients are just scattered. They're just scattered all over the place now. So finding patients, letting them know about events is getting harder and harder. And doing events is getting more complex because we don't have the pharmaceutical company support to do them. Because the company that paid for a lot of those was the company that made Elmiron, but yeah, they walked away 10 years ago. And honestly, I'm getting a little tired. I'm a little weary right now. We'll see. We'll see. Thank you, Renee. Thank you very much. All right, guys. Well, I think you're done. Are you done? Renee says, have you heard of a muscle therapy machine called Indibia? It helps me, but it's out of pocket. Actually, I think I swear, I just saved an article on that for my next magazine. So this is the radio frequency treatment. We've got a lot of different treatments like this now, because we've got diathermy, so I don't have, it's a radio frequency deep care that is non-invasive. It uses radio frequency to deliver heat to the skin and underlying tissues. Approved by the FDA. Does not damage the cells, and for this reason, there's no downtime or need to restore the condition of the tissue after treatment. And it activates fibroblasts, collagen, and elastin, which results in skin tightening and feeling very soft. It's used for excess fat and cellulite. It's used for localized fat deposits, skin tightening, facial rejuvenation, wrinkle reduction, hydration, fine line tightening. Let's just see if there's any research. Oh, wait. Is it Indibia or Intibia? A D or a T? Or maybe it's the same thing. Oh, no. Intibia is different. Okay. So I don't have any direct experience with patients on it. But if it's helping, power to you. Maybe that's something I should be doing underneath my incisions, because my incisions are still pretty darn tender. Christine on YouTube says, had a cystoscopy with hydro distension last Wednesday. Hope this second one holds. Honey, what'd they find when they looked in your bladder? What did the hydrodistension reveal? Like, did you have Hunner's lesions? Did you have petechial hemorrhaging? What did they see? Love to hear that. Renee says the Indivior is helpful and relaxing. It helps for a good while, helps with pain. But where do they do it, honey? Where do they do the Indivior? Do they do it on your lower abdomen? Do they do it on your glutes? I'm confused as to how they apply it for you that's helping your pelvic pain. Okay, so you had ulcers. Christine, you found ulcers. So did they treat the ulcers? Did they cauterize them or inject them with a steroid? Because normally when they find ulcers in the bladder, they're supposed to treat them at that time when they find them. He froze them. That's unusual. Okay. Okay. I can understand that. So, Christine, you might be very interested in a research study that came out last month, and I've got it right here. So, Hunner's lesions have been linked to viral infections in many patients, the Epstein-Barr virus, the polyoma virus. And that research was originally done like over 10 years ago in Europe, but our own National Institutes of Health confirmed it. Our own big IC research team, the MAP Research Network, looked at urine, and they too found latent viral infection in the urine of some patients with lesions. So they're now testing some antiviral meds for these patients. But amazingly, last month, we had a new study come out that used something called Lactoferrin. Lactoferrin is an over-the-counter supplement that has antibacterial, antiviral, and antifungal properties. Lactoferrin is the active ingredient in colostrum. Lactoferrin boosts the immune system. And that's why it's so important that children get the colostrum from their mom, because it helps to boost their immune system in a couple of very, very specific ways. Well, they have been testing lactoferrin now in adults with certain diseases. Last year, for example, this research team tested the ability of lactoferrin to reduce recurring UTIs from E. coli infections. And it was effective. It worked. They were able to prove that the simple over-the-counter supplement acted to reduce E. coli-based bladder infections. Well, they also this year studied it with IC. They were curious to see if lactoferrin would help IC. So they had 31 patients in the study. They did 5 a day for the first week. They did 2 a day for a month, and they did 1 a day for 3 months. 31 patients in the study. 28 out of 31 had no flares after treatment, and there were no side effects. Lactoferrin is found throughout the human body. It's found in all of our secretions, teardrops, etc. So 28 out of 31 symptoms were gone. 3 out of 31 had 1 flare. But then they looked at it a little bit more. The first thing they wanted to see is, did it change the inflammatory markers in our bloodstream? And it did. The lactoferrin patients had a reduction in something called interleukin 6. So that's huge, because that's showing now that it's reducing inflammation. But then they also studied the bladder wall. They studied the bladder wall, and something absolutely remarkable happened. Those very red inflamed walls became pink again. The redness disappeared. And more importantly, so did the lesions. The Hunner's lesions virtually disappeared. For the patients who had the lesions were gone. So this is a published study. I have it right here. Lactoferrin in the treatment of interstitial cystitis, a retrospective pilot study. It was published in the Journal of Biochemistry and Cell Biology. And the reason why I jumped on this, and I got this study like days after I had surgery, my double mastectomy. So here I am on pain meds, reading my email, and this goes by, and I'm like, what the hell is this? Right. And so I had to wait like 10 days before I could, like, I was on way too many pain meds. So I couldn't really do much. So I waited a good 10 days to 2 weeks. Then I looked at the study and I was stunned. Stunned at the promise of something as simple as this that might help some patients. Because this isn't just a company saying, hey, this will help. This is a validated research study that had really spectacular results. Now, at the end, they say we need to have more research, and I agree with that. And I'm in contact with that company now. Talk to them about being able to import their product. It's called Valpath here into the United States, but there's a bunch of hurdles to do that. So what I did instead is I looked for a really high quality lactoferrin supplement and brought it into the IC Network shop. Because if I had Hunner's lesions and I were in a lot of pain, and we've got a research study that says, hey, it might help that lesion with no side effects, I would consider that something worth trying. And it's affordable. Renee says she ordered it. She's praying it helps. I hope so too, hon. So Christine says, oh, good. Thank you. Tammy says, how would I take lactoferrin if I'm lactose intolerant? I have Hunner's lesions. I'm not sure. And I have to ask the researchers. So Tammy, if you can just hold that thought. I don't think it has lactose in it. You know what? Hold on a sec. Let me see if I can answer that question from the research team, the research team's website. Give me a quick moment here. Let me see if they've already answered this question. I mean, I'm pretty sure that they've removed all the lactose from it. Here, I'm not spelling it right. There's a really funky name. Let me make sure I'm spelling it. Oh, I see. I wasn't. All right. Valpath is a nutraceutical product that contains bovine lactoferrin, sodium bicarbonate, and sodium citrate. It's been studied for its biological activity, iron binding capacity, and resistance to digestion. Some studies suggest that Valpath may be effective in treating interstitial cystitis. Now, here's from the National. Okay, hold on. National Institutes of Health, 2024. Is this brand new? Here's another study. Oh, how cool is this? Okay, here, hold on. Let's see. So here's a full article. Let's see if they answer the question about lactose intolerance. No. Okay, so let's go to manufacturer's website. See, I've been wanting to get a copy of the label. And I asked them for the back side of the label because I haven't seen it. Okay, here it is. No, it does have lactose in it. It does. Okay. So that doesn't mean. Hold on. Let me send an email to the key researcher that I've been working with. All right. Okay, so hold on. Hi, Anna. Okay. Can someone who is lactose intolerant use your product? All right. I will get an answer for you. Okay. Christine, it's in the icing. Well, I found a couple of other brands of lactobacillus. Lactoferrin in the IC Network shop. We might be sold out now. I only got 12 bottles, but I have more coming in this week. So it's in the IC Network shop under Lactoferrin. It's in the pull down menu now. And I'm trying to bring another brand in that's more affordable. I got the best Lactoferrin I could find, but it came from Australia and it's $75 a bottle. So I'm working with an American company right now that's half that price. I'm trying to bring that on. Yeah, and it is over the counter. Okay. Marilyn says, I've been using 1 gram of estrace for the past year on the advice of my urologist because he described it. I have complicated UTIs. My primary alarmed me by saying because I had breast cancer 7 years ago, so I stopped using it till I could see my oncologist. Well, the problem is that I had the worst migraine with aura since I passed menopause. Your thoughts? Marilyn, this was a question I asked my oncologist literally a month ago because I am being treated for breast cancer. I had my breast removed in July. And my oncologist said she was not worried at all about the use of topical estrogen contributing to breast cancer, that the new research shows that it stays in the tissue, that it does not migrate. Now, that said, I completely understand your fear because I had that fear too. I mean, it's easy to say it, but once you're dealing with the reality of cancer and the trauma of cancer and the fear of cancer and the treatment for cancer, it puts it on a whole new level. And so I will say that I did stop using mine for like a month until I had my surgery, and I still had a really good conversation with the oncologist. Now I'm using it again, but I will confess that I'm not using it as frequently. And I'm using it the way I always used it, which is really at the entrance to my vagina and the entrance to my urethra and on my vulva. I'm not doing it internally in my vagina because I'm not, number one, I'm not struggling with recurring UTIs. If I ever had recurring UTIs, yes, I would be using it vaginally because that's where bacteria tend to multiply in patients who have recurring UTIs. It's usually in the vagina about 24 hours before it arrives in the bladder. Or if I were having sex again, been a while. It's been a while, I'm sorry to say. then I would consider doing it internally. But for me right now, doing a little bit externally, I'm not worried about. But again, that's a conversation you have to have with your doctor, and I would encourage you to look at the research yourself. Marlia says, I only caught the tail end about lactobacillus. I see inners. What happens with that? With the lactobacillus inners, hon? Well, we're still waiting for more research. What we know, based upon the biome studies, is that patients who are in the bladder wall phenotype have an overabundance of a pathogenic lactobacillus inners. The question now is, how do we treat it? How do we treat it? And we don't have answers for that yet. That's not in all patients, but in just with this small subset of patients, we now have that smoking gun bacteria that could be playing a role in their symptoms. But again, if you're pelvic floor driven, as 85% of IC patients are, you have a normal biome and lactobacillus inners isn't playing a role. The other thing we have to remember is that antibiotic use distorts the biome and allows lactobacillus inners to gain a foothold and dominate. So what we're really trying to do is to try to discourage patients from self-treating flares with antibiotics, because you're creating a foundation for bad things to happen. Renee says, do I have your credit card? I don't know without looking it up. I can look up your order for you. Here, hold on a sec. All right, let me see what I can find here. Okay, Renee, you placed an order on the 12th. For Lactoferrin. All right, you're good. It's already shipped out, honey. It's already shipped out. We already have a tracking. Actually, you placed the order before that. It shipped out on the 12th. So you'll have it early next week. Let me grab this tracking number here real quick, and we can look at it. And guys, I'm here as long as you have questions. So please ask your questions. If we're done with questions, then we can go do other things. I feel like I want to make soup for dinner tonight. Your expected delivery is Wednesday. It is currently in Atlanta. It's in Atlanta right now. Pauline says, God bless you, Jill, for all that you do. Not sure what we would have ever done without you and your wonderful advice. Happy to be here, hun. But you guys, if you find these meetings helpful, you got to keep us going. And the way you keep us going is by becoming a member. Because there's a lot of bills associated with running the IC network. You know, I mean, just our internet bill alone is like $500 a month. But there's more. I mean, that's just for me to get on the internet to do these meetings. That's not web hosting or anything at all like that. So we really need members. So please think about becoming a member, and you'll get our magazine, the IC Optimist, which is, in my opinion, where I do my best work. All right. Okay, hold on one sec. Okay. Janelle says, any information on low-dose naltrexone helpful for IC? Okay, so we have 1 or 2 studies with low-dose naltrexone. Let me grab them. one study. And this is a study actually of chronic pain, not just IC. So let's look at this real quick. This is from 2020. So they were trying to evaluate the efficacy of low-dose naltrexone in the management of chronic pain. They looked at 793 studies, and 8 articles were selected for evaluation. 4 were case reports, 3 clinical studies, one randomized controlled trial. Low-dose naltrexone provides an alternative in medical management of chronic pain as a novel anti-inflammatory and immunomodulator. It can offer additional management options. So hold on. Here's one for chronic regional pain syndrome, one for the pain of multiple sclerosis. Let's look at this. The safety and efficacy of low-dose naltrexone in the management of chronic pain and inflammation in MS, fibro, Crohn's disease, and other chronic pain disorders. Low-dose naltrexone has been used off-label for the treatment of pain and inflammation in MS, Crohn's, fibro, and other diseases. It is hypothesized that the lower than standard doses of naltrexone inhibit cellular. Well, let's see. You don't need to know all that. It has an analgesic and anti-inflammatory effect. Currently, the research shows it supports the safety and tolerability of it. That it's better than placebo, but more objective measures are needed and more randomized controlled trials are needed. I don't have too many patients who have tried low-dose naltrexone, to be quite honest. I wish I had more info for you. I just don't. How do you calm a flare after stress? And Shelly, hold that thought, girl. We're going to talk about that. So when we think about flares, we have to remember there are different types of flares. So you can have a bladder wall flare from eating something really acidic or alcoholic. So if you have Hunner's lesions, you got wounds in your bladder, you pour alcohol on that lesion, acid on that lesion, it's going to hurt like hell. So that's a bladder wall flare. And the way we treat that flare is by diluting the acid with water. Then we're going to alkalinize urine with a little bit of Prelief. Then we're going to numb the bladder wall with some bladder pain relief tablets. And if after a couple of days that's not enough, then you can go in and have a rescue installation at your doctor. So that's a bladder wall flare. A pelvic floor flare is treated with things that will relax muscles. So if you've gotten a flare from sex or from driving in a car for a long period of time, well, the first thing we'd normally do is grab a heating pad, lay in your recliner on your bed for 15 minutes. Let's see if we can get heat to relax these muscles. If that doesn't work, sitting in a warm tub or taking a hot shower, that's the next thing to try. Then after that, we can do a muscle relaxant. Hopefully you're already under the care of a physical therapist and a doctor about it, and they have given you a skeletal muscle relaxant like baclofen or Flexeril to use during pelvic floor flares. And then after a couple of days, if we're still in that pelvic floor flare, getting back to that physical therapist or you using your wand to massage these muscles internally to release the tension in that muscle. So that stress flare, there are 2 things you have to accomplish. Stress causes you to tighten muscles. So most stress flares involve very tight pelvic floor muscles. So you do the muscle relaxation protocol. Heat, muscle relaxants, using your internal wand, physical therapy. If pain is an issue, then we want to go in maybe with some Tylenol, Advil, etc. But then we also have to really work on calming your central nervous system down, because the more stressed you are, the more pain you will be in, because your brain sees the stress, sees the pain, and goes, uh-oh, something really bad's happening. Your life may be at stake. So your brain starts to make the pain even more intense, because your brain's trying to get you to take action, because your brain is assuming it's a big stressor, like a saber-toothed tiger running after you, or something like you're being bitten by something, whatever. Very, very primitive. Fight or flight is a very, very primitive part of our brain. So this is where mindfulness really matters, doing things that will calm your central nervous system down, deep breathing, things like that. Guided relaxations, doing some of the techniques that we've done in our meetings, like I Spy, working on that anxiety, working on getting rid of those negative thoughts. Because whenever you have a negative thought, you scare your brain, and then you go right back into fight or flight and pelvic floor tension. And then that's where Peora can be very, very helpful. So hold on a sec. PEA, and then where did it go? Oh, here we go. So the other thing we can use to try to calm muscles down, calm nerves down, is PEA, palmitoyl-ethanolamine. Got good research behind it showing it's very effective at reducing a lot of pain conditions, not just IC. In the IC study, 87% of IC patients reported significant reductions in their pain by month 3. And the really cool thing about PEA is it's really ideal for people in the widespread pain phenotype. So like, this is what I take, because I'm very, very invested in keeping my nerves as calm as I can. And then one last thing for the bladder wall flare, and they have a new label. This isn't the right label. I just have an older bottle. Allopath. Allopath combines the soothing effect of aloe for the bladder wall with the nerve calming effects of PEA. So a lot of patients are now using aloe for bladder wall flares. Okay, it's just soothing and calming. This combination of the two, it's much better than just plain aloe, because you've got two methods of action that are helping calm those tissues down. Now let's talk about Shelley here for a moment. Shelley says, Elmiron ruins my eyes. People need to beware. Shelley, you may not know, but I'm the person who actually broke that news to the IC world 4 years ago. This was, in fact, it was exactly this time of year. It was over Labor Day, and I was going through the new research for IC to look for articles that I could write for our website and for our magazine, when I found this little letter to the editor from the researchers, the eye researchers at Emory University, who said they believed that they'd found a new eye disease associated with the use of Elmiron. I have it. I have a whole file on it. And I'm like, what? It was quite concerning. And so I got a copy of their letter, and it was basically, we want to inform urologists that we believe that we have found this new eye disease associated with the use of this medication. And their concern was that the eye damage could progress even after stopping the medication. That was something that they expressed in that letter. So they had done a research study that they had, or a case series that they'd published in the spring of that year. And of course, urologists don't read eye journals. Urologists had no clue this was happening. So then I went and I got that paper, and let me see let's see. Where is it? Where did I put it? I haven't pulled these out in a while. Is it there? No. Well, I'd have to dig to find it. I would have to dig to find my big file that has all the articles on it. So this journal article was devastating. This case series, there was 6 patients, all had IC, all using Elmiron. They all had eye disease. And their original assumption was the longer you used it, the greater the risk of eye damage. But in that case series, the patient with the worst eye damage was the youngest patient who had used it the least. And there were pictures of how the eyes were damaged. There are pictures of the retina that showed big spots on the retina where the retina had clearly changed. So I'm literally sitting where I'm sitting right now. This is where I was sitting as I was reading this. And I just burst into tears. I was like, oh my God. There are thousands of patients who have used this medication. Could this be real? Any correlation between the bladder and the eyes? Huh? Like what? How is that even possible? So what I did is I emailed the top IC doctors that I know, the top doctors in the United States. And I said, okay, do you know about this? Let's credibility test it. Let's just credibility test it. I got 30,000 people, IC patients I can email. Let's do a small survey. And let's just ask about the incidence of retinal disease, if they used Elmiron and if they had eye issues. And then Rob Muldren helped me refine the survey. And a week later, I sent it out. And I have to tell you that was the moment that I'm probably the most proud of in my entire career. Because I could have sat on it for a year and waited for more research. But I couldn't in good conscience do that because I believe in informed consent. I believe that every patient should know the potential risks of the medications they're taking. And even my attorney at the time said, yeah, you shouldn't do this. And I'm like, I have to do this. I have to let patients know about this. So I sent out that first blast email that educated the IC world about this problem. And I had my first phone call within 20 minutes. I had a patient call sobbing, going, oh my God, thank you. We've been trying to figure out why I've been going blind. You just solved it. And then a day or two later, I got a phone call from a young woman who took Elmiron while she was pregnant, and her baby was born with severe eye damage. And she called crying, going, did I do this to my baby? And I said, I don't know. I don't know. That only happened one time. So of course so we had our survey. And within a week, I had 300 patients. And within 2 months, I had 1,000 patients. And within 6 months, I had 2,000 patients. How many do you think reported retinal disease? Emory thought it was 30%. In my study, over 50% of patients using Elmiron reported changes in their retina. 50, over 50%. Now the problem with my study is that I couldn't pull out heredity and eye issues from heredity. So mine was a shot in the dark. But the data was stunning. So I sent it off to the top IC researcher at the National Institutes of Health. He looked at it and he was like, oh my God, incredible work. You need to send this to the FDA so that we can get a warning on it. And so we sent all the data to the FDA and they didn't respond. But then 2 years later, I got a letter saying they ignored it because the company did their own black box warning after all. So it rendered my request for a warning neutral. Now, in the meantime, hundreds and hundreds of patients have sued the company. And the company's paying them off now. So Shelley, I hope you got a settlement. The low ball figure I heard, but I have no idea if this is true or not, was the minimum was like two or $300,000, and the maximum I heard was up to $1 million. You did good, honey. Good. So here's the thing you might not know. I got subpoenaed by the federal court in New Jersey. I never in my life thought that I would see my name on a federal subpoena because I did that study. And an attorney, one of the attorneys for the plaintiffs warned me this would happen. And she said, "Get ready. They're going to try to destroy you. They're going to look for anything they can do to discredit your research and to discredit you." So I had to hire an attorney to represent me with that federal, because you can't ignore a federal subpoena. You go to jail. And that cost me about $20,000, for which I will never get that money back. Because I was fighting for you. I was fighting for all those patients. So if you can, Shelley, think about becoming a member of the IC network to help me get some of that money back. Because that was a massive financial toll for me personally. And that money came right out of my retirement fund. And so for those who got settlements, I'm just kind of like saying, would you please consider just becoming a member, please, to help us? I would appreciate that very, very much. But I'm really, you would just go to the IC Network website and go into our shop. And ICN memberships are there, and donations are there. It's all sorts of things. We have all of our products there, our books and our chair cushions and heating pads and memberships and magazines and all sorts of stuff. Now, if you could spread the word to any other ICers who got their settlements, just a little bit of help would be appreciated. Somebody said I should do a GoFundMe, but I don't know. I just want the word to be spread. I mean, I'm really glad that I was able to get that started so that you got compensated. And because the real tragedy here is that if you look at the very first clinical trial for Elmiron that led to its FDA, its approval, they found eye problems. They found retinal hemorrhaging, and there were a couple of others in there. They didn't describe it as pigmentary maculopathy, but there were eye problems. And the Emory researchers found that. And yet, if you look at the patient educational materials that were published, because I had all of those, I had a whole box of the original patient education materials. They never mentioned eye stuff. They mentioned all the other side effects, but they didn't mention the eye stuff. And that to me was the key question: is why? Did they follow up on the eye stuff? Did they do anything to look at the long-term effects to the eyes? And I don't know. Once I got subpoenaed, everybody had to stop talking to me because all of my communications with doctors, et cetera, and attorneys had to be revealed to the court. And so I haven't talked to an attorney since I got subpoenaed. So I literally only have heard from patients who've shared. Shelley says her eyes bleed behind it. Yeah, that's that retinal hemorrhaging. Pauline said, Jill, with what some people are doing, GoFundMe for you, you're way more entitled to do that. I'm sure our IC community would reach out. I'll think about it. I'll think about it. I just, I'm really proud of what I did. I think it was the single most important thing I've done in 30 years. And I know that there are people in the industry that absolutely hate my guts now. I know that there are some doctors who hate my guts now because I did that. And I will say that our next AUA conference is in Las Vegas next year. I'm a little intimidated to go to that conference and see some of these people because I've cost that company millions of dollars. I need a football playing boyfriend. I just don't I just don't know if I would I don't think I feel safe. Yeah, no, I'm very proud of what I've done. I absolutely hold my head up high. I just don't know if I feel safe. I mean, I was warned. I was warned by one of the attorneys. So we'll see. But anyway, if you could just spread the word to your fellow people that if they could come on over to the IC network and support us, that would be great. Renee says, and don't go. Well, I kind of need to go. I need to go. I really need to go. Hmm. I don't know. Maybe I'll hire a bodyguard. I might. I haven't, you guys, I haven't said that to anybody. I haven't said that to anybody, but let's just say there have been attempts to intimidate. Warrior girl. Cassidy said, I had the InterStim trial done in May, which unfortunately failed. Also tried cystoscopy, hydrodistension, ulcer treatment, steroid injection, and an ulcer in one surgery, which also failed. Everything that is in guidelines for treatment, I have failed. And even some other treatments not in the guidelines. My doctor is now recommending behavioral therapy because she can't do anything else as I'm 17. My doctor doesn't know of any doctor willing to even talk about bladder removal. Okay, Cassidy, girl. Number one, you're not alone. Number two, I hear you because I've been there. Number three, what do our guidelines say? If treatments are failing, take a step back and revisit the diagnosis. What have we missed? What have we missed? Clearly, they've missed something for you. And so it all comes down to your phenotype. Are you familiar with the concept of a phenotype? Because they're throwing the kitchen sink at you, but they're all guesses. They aren't facts. We need facts. We need to know what the hell is happening in your bladder. Okay, so you have lesions, so you're in that phenotype. Okay, so you are a perfect candidate to try lactoferrin. So remember, lesions have now been linked to viral infections. There are three theories about what causes a lesion. Okay, because a lesion is a visible wound in the bladder. So theory number one, and like the first thing everybody had to accept is that when you biopsy a lesion, there is massive inflammation. But you biopsy the bladder of somebody who doesn't have lesions, and it's normal tissue. There's no inflammation. So people with lesions have this massive inflammatory process happening in their bladder. And inflammation is basically the equivalent of a biological war. Shelley, hold that thought. Okay, because it's really important for you too. So inflammation is a sign of a warfare happening. Your body's immune system is fighting something. So the question is, what is it fighting? Well, it was researchers in Europe about 10 years ago who found something. They found viruses in the urine of IC patients that was not found. I mean, the urine of Hunner's lesion patients, it was not found in patients without lesions. Multiple studies. We're reading these studies going, what? So the virus is a polyoma virus or the Epstein-Barr virus. If you ever had mono, the Epstein-Barr virus. So we're all reading this going, finally, we have a clue as to what causes lesions. But then the American infrastructure, the IC researchers in America, literally had no comment for 5 years. Like, we're like going, what do you think of the viral theory? What do you think? What do you think? Well, what we didn't know is that our big IC research team, the MAP Research Network, that's called the Multidisciplinary Approach for the Study of Pelvic Pain. That's our IC Research Network. They were doing their own viral study because they had urine samples over time from a couple hundred patients. And you know what they found? Virus. So, and this is all fairly recent, the last 3-4 years or so. I've done several articles on it on our website whenever these new studies came out. And so now multiple research teams around the world now with next generation DNA urine testing are now identifying Epstein-Barr or polyoma in patients with Hunner's lesions. And they're testing antivirals. Valacyclovir, I just pulled the study yesterday, was the first one where they did next generation testing. They identified the virus. Every single Hunner's lesion patient in that study had Epstein-Barr virus. Every single patient. When they treated them with the antiviral, they were able to put the virus into, just the virus disappeared. Okay. With the use of an antiviral therapy. And this is where, again, like I said earlier, I mean, you can ask the doctor to do a blood test to see if you have any active or passive viral infections going on in your body. And this is where lactoferrin would be reasonable, since we have the brand new study that came out last month, which lactoferrin is an over-the-counter supplement that has antiviral, antifungal, antibacterial properties. It comes from colostrum. It is an essential part of our immune system. All of our secretions have lactoferrin in it. So they take the lactoferrin from cows and they give it to humans. And the study last month that was published, that I've talked about now for a couple of weeks, had the Hunner's lesions disappear in the great majority of patients. Okay, so theory number one, Hunner's lesions are a viral infection. Theory number two is Hunner's lesions are the result of tremendous nerve inflammation. Yes, Renee. Tremendous nerve inflammation, that nerves that are very, very inflamed release something called substance P, which damages tissue. So substance P could cause a wound. So what could cause neuroinflammation? Well, that's the $6 million question. So 2 or 3 years ago, we had a case study published of a woman with severe Hunner's lesion who also had a severe prolapse. And when they went in to repair the prolapse, they made a remarkable discovery that her uterus was turned backwards, that the front of her uterus was facing backwards and the back of her uterus was facing frontwards. She had what we call a strangulation problem. because one of the ligaments that normally holds the uterus in place had broken. So now her uterus was free swinging around one ligament and it was backwards. This is called posterior fornix syndrome, where one of these fornixes breaks. Now, what they did is they surgically repaired it. They untwisted her uterus and reattached it. They dealt with the prolapse, and something absolutely remarkable happened. Her lesions completely disappeared. She is considered a complete and total cure. So that's an example of, because she had this twisting injury, the nerves became very, very inflamed. And once they untwisted it, restored proper blood supply for the nerves, the neuroinflammation improved and her symptoms went away. So how do they test for posterior fornix syndrome? And there is an article on our website about this. So the title of it is something like "Woman Remarkably Cured of Hunner's Lesions," and it came straight from the research journal. And I've got links to all those to the paper, so you can print it out and you can give it to your doctor. So what's interesting, and this just happened a couple months ago, if you look at the people who deal with posterior fornix syndrome, they've been saying for decades they cause bladder problems. And there was just something that crossed my desk before my surgery where, and I don't remember exactly what it was, but it was, what journal it came out of, but it was this confirmation from these posterior fornix experts that this is often missed in patients diagnosed with IC. They've known for years that this problem with this ligament can result in urinary issues. So that was interesting to read because they've been talking about this for 30 or 40 years, but nobody ever talked to the patients about it. Okay, so how do you check for posterior fornix syndrome? It's really, really easy. Here, I have to draw a picture though, so hold on a sec. Let me grab a piece of paper. And let me see if I can get a big pen. Let's see. So when you think about your cervix, which is the entrance to your uterus, it's not flat. It's not like the vagina ends and the cervix begins. There's pockets. And so, hold on a sec. Okay, this is a really rough drawing, so bear with me here. Okay. So here's your vagina. Here's your uterus. Here's your cervix. So this is not straight up and down. There are little pockets that go around your cervix. And so what they do is they stick a wooden speculum in one of these pockets and then lift it a little bit. And if by lifting it, the symptoms improve, that tells us that we have a problem with this ligament or this ligament. So this is a fornix. This little pocket, I believe, this is the fornix. So this is called posterior fornix syndrome. So that's something else that you can look at too, especially if you've had any big falls or injuries. If you were an athlete as a teenager, that would be a big risk factor for having an injury that might have caused a ligament to separate. Okay, so to sum up, we've got a viral implication, we've got a neuroinflammation implication, and now we have a broken ligament implication to the development of Hunner's lesions. You are an anatomical mystery to be solved. And so these are things I think you could consider, and asking for that viral test to see if you happen to have Epstein-Barr. And if you do, then asking for an antiviral like Valtrex makes total sense to me. And we have the research to back it up. Asking them to check to see if you have posterior fornix syndrome. Easy peasy. Take them 5 seconds to do it, your next vaginal exam. And it might be an interesting experiment to try a little bit of lactoferrin for a couple of months, since it has natural antiviral properties, to see if that would help, because we've got the research to back that up too. And I would be happy to talk with you and show you that research, or send you that research so you can look at it, because I'm excited about it, because this is the first time, literally, in the last month where we've had an over-the-counter product that has shown success in reducing Hunner's lesions. Shelly says, do they know what causes IC? So Shelly, yeah, Cassidy, there is here, I can get that. Here, hold on. I have blogs on our website about it. Let me see if I can grab you a link real quick. So you want the lactoferrin research or the posterior? Here, let me give you the lactoferrin research study first. Okay. Now, unfortunately, you have to buy. So this is just to the abstract. Okay, so there's the lactoferrin research. Published August 1st of this year. And then, hold on a sec. Let me also give you here you go. I want to give you this one too. Okay, so getting back to Shelly. Okay, Shelly, here's the mind-blowing part of this. You asked, what's the cause of IC? We don't even think of IC as a bladder disease anymore. We don't. And our latest national guidelines say that our national guidelines say that no bladder disease is found in the vast majority of patients. The only patients who show signs of a disease process are patients with Hunner's lesions or patients with chronic UTI. For the rest of us, IC actually is neuromuscular in origin, that it's nerves and or muscles that are causing the urinary symptoms that you associate with IC: frequency, urgency, pressure, pain. Okay, so that's a mind blower. And that started back in 2008, when we had our first research study that showed that physical therapy outperformed Elmiron. Physical therapy was far more effective than any bladder med in reducing the symptoms of IC. We knew that almost 20 years ago. And that's when the IC world turned on its head, because up to that point, everybody's going, well, bladder disease, incurable bladder disease, give them Elmiron, give them an antidepressant in the diet and send them on their way. But then we've got this valid study that shows that physical therapy was incredibly effective at reducing symptoms, and I'm one of those patients. And that's when the IC world went, uh-oh, wait a second. Maybe this isn't a bladder disease in some patients. Maybe it's a muscle problem. And since that time, we now know that it's dominantly a muscle problem. Okay, so that's concept number one. Concept number two is that the IC patient population is very diverse and robust. You've got patients whose IC began in childhood, others whose IC began after menopause. They have the same diagnosis, interstitial cystitis, but are they really the same? And the answer, of course, is no. They're not biologically, pathologically the same. For some people, IC begins while they're going through chemotherapy because the chemicals of the chemo damage the bladder wall. While for others, IC begins after they fall on their tailbone. Again, they have the same diagnosis, but are they really the same? And the answer, of course, is no, they're not. And the hard fact is pretty much every bladder treatment clinical trial has failed. They've invested over $100 million into studying new treatments for IC, and all those studies have failed. The only study that succeeded was the physical therapy study. Why? Why? And that's straight from the team, the National Institutes of Health team and spokesperson. They admit they failed. Why? Here's why. Because you can't put apples, oranges, and bananas in the same study and expect success. The IC patient population is very, very diverse. And it's the diversity that sabotages the studies. We call this phenotyping. We have to figure out what group you're in to find the right treatment for you. So I use a system that was created by the doctor who ran the IC research program at Stanford University for 5 years. And again, the powers that be all now recognize and admit there are groups, each with their own treatment. So you and I were diagnosed back in the day when we were all assumed that we had a bladder disease. It's very different now. So in the pain system, Christopher Payne, that's his name, the first group is Hunner's lesions, the patients who have visible wounds on their bladder. That's only 5, maybe 10% of patients. And just as I explained earlier, we now know what can cause those viral infections and the stuff. So now we know why patients with Hunner's lesions never responded to Elmiron or any other treatment, because for many of them, it's a virus. Okay. They weren't getting the right treatment. Okay, that's one group. Our second group is bladder wall driven. So in this group, these are patients who have pain as their bladder fills with urine that is relieved by urination. So the fuller they get, the worse they feel. Once they pee, they feel better. So in this group, we're going to look for, number one, a chemical injury to the bladder wall. Because the bladder, like any other part of the body, can be hurt. It's hurt through chemical exposure. So these are the patients who get IC from chemotherapy or get IC because they drink way too much diet soda, coffee, etc. So therapeutically for them, we have to figure out what the irritant is, get rid of the irritant, and allow the bladder to heal accordingly. Because the bladder will heal. It just takes a long time to heal. The second thing we're going to look at in the bladder wall group is estrogen atrophy. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a real evolutionary marvel. Well, it turns out the way your bladder defends itself is with a really thick coating of mucus. So your bladder is like your mouth. It's a hollow organ that's wet on the inside. And that mucus acts as a barrier. It keeps the urine off of the fragile cells of the bladder wall. So the more mucus, the better. Unfortunately, mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. But if you're on birth control, if you're on Lupron for endo, or you're just getting older, you don't have the estrogen, which means you don't have as much mucus, which means your bladder's ability to defend itself is compromised. We call this the genitourinary syndrome of menopause. And we have a case study of an 18-year-old who developed IC symptoms. And she had diagnosed with IC, diagnosed with yeast, diagnosed with recurring UTI. A year later, they figured out it was her birth control. And when they stopped the birth control, it took several weeks, but her symptoms finally got better. Okay, so your bladder is estrogen dependent. Our third group that we look for is pelvic floor injury. This is our biggest group. 85% of patients are in this group. So these are patients where there's a physical trauma that has caused their symptoms. Falling down the stairs, falling on their tailbone, a history of athletics, or if you have one leg longer than the other. If you've broken your tailbone, if your tailbone's crooked, then muscles are crooked. So for this group of patients, when we find these tight pelvic floor muscles, the correct treatment for them is physical therapy. We've got to get these muscles relaxed and released. Tight muscles restrict blood supply. Tight muscles hurt nerves. So our therapeutic priority when we find pelvic floor tension is to send them to physical therapy. And interestingly, in our AUA guidelines that were updated 2 years ago, there's only 2 recommendations. Recommendation number 1 is if you suspect Hunner's lesions, look for them. Recommendation number 2 is if you find pelvic floor tension, send them to physical therapy immediately. And Shelley, I did bladder treat. I'm a pharmacologist. I was here when Elmiron was approved. As a pharmacologist, Elmiron never made sense to me. If you swallowed a Band-Aid, would you expect it to come out the other end of Band-Aid? And the answer, of course, is no. Most of it's destroyed by digestion. So like 92% is destroyed by digestion, according to their own studies. So I chose never to go on Elmiron because it never made sense to me. And so I consider myself pretty lucky that I didn't fall into that group. But many, many thousands of patients were prescribed a bladder coating therapy like Elmiron. Okay. What finally worked for me was physical therapy because my muscles were very, very tight. And it all went back to me breaking my tailbone in 7th grade, when my symptoms started in 7th grade. Okay. Group number 4 is pudendal neuralgia. These are patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts. When they bend over, it hurts. They might have pins and needles. They might have areas of numbness. They might have PGAD, where you feel this funky arousal sensation that happens randomly. In this case, we have muscle squeezing nerves. Anytime pain changes with body movement, that's not your bladder, that's muscles and nerves. And it's amazing how often that happens. So if your pain gets worse when you sit down, you're better when you stand up, that tells me we're dealing with muscle stuff. Or if patients who have more pain when they walk around, that tells me we're looking in all likelihood for muscle dysfunction. So therapy for PNE is to calm the muscles down and to calm the nerves down. And our last group is called widespread pain, chronic overlapping pain conditions. This is the ultimate fly in the ointment of these research studies, because everybody now all admit that it's a widespread pain patients that pretty much sabotage a lot of that research. So widespread pain are patients who have multiple pain conditions. I'm also in this group. IC, IBS, vulvodynia, TMJ, migraines, fibromyalgia. This is characterized by having very sensitive skin, a wicked sense of smell. This is essentially now believed to be an injury to the central nervous system. And so therapeutically, what we're going to do is we're going to calm and soothe the central nervous system. Patients who have multiple pain conditions struggle with high levels of anxiety. That's very common. It's well documented in the IC patient population. I had terrible anxiety as a teenager and in my 20s. Why? Why does this happen? Why do some people develop widespread pain and others don't? Well, what the research shows is that for 80% of the kids who develop widespread pain as an adult, there is a major physical injury. A major physical injury. All it takes is 14 days of pain to put the brain into a constant state of fight or flight. And it's that constant state of fight or flight that's driving all of this. So for 80%, it's a physical injury. And for 20%, it's a history of abuse and bullying. And I have made no secret of the fact that I grew up in a neighborhood with a kid that became a rapist and murderer. and I was attacked in 4th grade. And I did not leave my home without fear for a decade. That also played a tremendous role in why I struggled with multiple pain conditions. Now, the blessing here is that I'm pain-free now the great majority of the time. Why? Number one, it took all the shame and blame away. I was very ashamed of it for years. Now I know it just happens when you're hurt. I was hurt. It wasn't my fault. And I worked on getting the anxiety under control. That was huge for me. And I work on calming my nerves down every single day. I'm also a redhead, so I'm already sensitive anyway from that. And a lot of people ask me what I do, and this is what I do. As I have a healthy bladder, I don't need to do bladder treatments. What I have is a super sensitive nervous system, and so I do this to calm and soothe my nervous system. And this is available in the IC Network shop. And there's research behind this showing that it's palmitoyl ethanolamide can be very successful at reducing IC pain. Cindy said, if my doctor saw inflammation during cysto, is that the same thing as lesions? Not at all. Shelley said she'd bruised her tailbone. So Shelley, have you had a pelvic floor assessment? That's very, very important now. Because if you bruise your tailbone or your tailbone was broken and healed out of position, the odds are you have tight pelvic floor muscles. Mandy said, talked to you last week on Zoom. I was the one from New Zealand. I feel like I didn't explain things properly. So I sent you an email after last week and tried to explain things better. Was just wondering if you had read it. Mandy, I don't remember seeing that email. Could you send it again? I don't remember seeing that. And put in capital letters, Mandy, New Zealand, second attempt, so that it really pops off, because I get so many emails every day, but I don't remember seeing that, honey. I'm sorry. Yeah. So phenotyping is everything now. And now we, like I said when I started this meeting, we're long past the days of telling patients they have an incurable bladder disease. Here's a bladder med. Here's an antidepressant. Here's an antihistamine. Here's the diet. We'll see you in 6 months. We're not doing that anymore. The blessing now is that patients who are diagnosed today are going to have a much easier pathway to success in reducing their symptoms than we did 20 and 30 years ago. So you're not alone, my dear. You are not alone. Boy, can I talk? Holy hell. Mukund says, thank you sincerely for your good work. My sister had similar issue with constant chronic bladder pain. Our family is very worried. The doctor says she has interstitial cystitis. They've tried everything, diet, fluids, even weekly bladder installs, but there's no relief. She's in pain every day. The doctor also showed us a video of her bladder and explained that when they fill it with water, her bladder can't hold it and the nerves start reacting painfully. If you understand this, can you recommend anything to help relieving her pain? This might help calm those nerves down. Palmitoyl ethanolamide, we call it Piora. But we still have to figure out why the nerves are so sensitive. Are the nerves sensitive because she's been injured? It's possible. Has she ever fallen on her pelvis, fallen on her tailbone? Is there an old injury? And or if she has pain throughout her body, and if her skin is very sensitive and she has that wicked sense of smell, then we're dealing with an injury to the central nervous system. And again, this is where something like PEA would be helpful. But at the same time, there's other things that we can do to calm the central nervous system down. I would be happy to talk to you or talk to her and walk you through some techniques that we do to try to reverse that central nervous system injury. Sharon says, you didn't need chemo? No, I didn't. I was terrified of chemo because I knew chemo could badly affect the bladder. But I had ductal carcinoma in situ stage 0. And the pathology found that the cancer had not moved outside of the ducts that they could see, and both the surgical margins and my lymph nodes. They took a couple of lymph nodes were clear, and so they consider that a cure. It's a 97% cure rate. Although the oncologist then said if there was a microscopic cancer cell that they missed, you could end up with cancer on your chest wall. So you have to keep monitoring your chest for anything unusual. I didn't want to hear that. We do have, for certain types of chemo, and this is what I do in the afternoons. It's just like I'm wearing a, I don't know if you can see this or not. See this? My incisions go from here to here and here to here. And there's still hundreds of stitches. I think you can see. There you go. Can you see that? So they're very sensitive and they need to be supported from the bottom. If I don't wear this, there's too much pressure on them and they hurt a lot. And the other patients in my breast cancer support group, yes, I'm a member. I'm not the leader of the breast cancer support group. I'm a member. It's very weird. I'm the only one who has pain 2 months later. And what they're saying is that it's a combination of my very sensitive nervous system and being a redhead combined with the fact that my body is rejecting some of the stitches. So I feel the stitches are not going to dissolve for another couple months. And so underneath the incision, there are stitches holding my bits together. And I feel them when I move my body. It sucks. I was not prepared for this recovery. I was not prepared I just wasn't prepared for dealing with such big, painful incisions. I just wasn't. So I had moments when I just cry, like I did last night. It was like, oh, I'm done. I mean, I don't have any regrets. I'm happy to let the breast go, but it's just too much trauma. I think I've already started doing some therapy, but I think I need to go do like a really big trauma workshop because I just feel really traumatized. All right, Pamela said, I brain surgery in 1999 and after all meds were gone, my IC bladder, vulvodynia, pudendal nerve, fibro. Yeah, each doctor has its own ideas. Pamela, I mean, that's widespread pain. I mean, you had brain surgery, which traumatized your central nervous system. A traumatized central nervous system or an injured central nervous system becomes a sensitive central nervous system, which means, so the odds are you probably also have some small fiber polyneuropathy, like I do, where your skin is very, very sensitive. And so what the research from the Chronic Pain Research Alliance shows is that we're dealing with an injured, traumatized central nervous system that is essentially stuck in fight or flight. And we have to break that. We got to break your brain out of fight or flight. It's really easy to do to get all those nerves to calm down. I mean, it's very primitive. I mean, think about it. You had brain surgery. How does your body respond to that? How does your brain respond to that? Your brain goes, holy hell, what just happened? It hurts. And your fight or flight instinct takes over. That fight or flight response from your brainstem immediately takes control of the brain because you were severely traumatized by having brain surgery. So the question now is, is that it kind of hijacks the central nervous system, and it can cause long-term problems over time, over a lifetime. And what that research alliance shows is for patients who have widespread pain, like you and me, that we have a brain that's just stuck in fight or flight. So therapeutically, what we have to do is get the brain out of fight or flight. And we do that with really good mind-body medicine techniques, mindfulness techniques. I'd be happy to talk to you the next week if you want to. I can share with you the techniques that I use, and they've worked beautifully. And now my pain is gone. The vast majority of my pain is gone. The bladder pain's gone. The vulvodynia is gone. The IBS is gone. The fibro is gone. The pudendal, if I sit too long, my nerve starts to quiver. My dominant problem is my jaw because I just talk too long. So Diane says, pelvic floor physical therapy, the antidote for a crooked tailbone. It's a big part of it. But then we had one patient who also did some chiropractor work to try to get her tailbone back into position. That's a case study that I shared on our website and in our magazine. Mandy said, I will try to send another email. Thank you, honey. icnetwork@mac.com. icnetwork@mac. That's short for Macintosh computer. icnetwork@mac.com. Send it again. Be the squeaky wheel. Anybody can be the squeaky wheel. If you call, leave a message, keep calling. I promise I will get back. I just get very distracted. And I'm dealing with my own stuff. So, if my incisions start to hurt, I step away from the desk. I can get in like 5 hours of work before I have to start doing this. Sharon said, did you say 14 days of pain? 14 days of pain will put the brain into a constant state of fight or flight. 20 or 21 days of abuse will do exactly the same. That's in children and adults. If you start a new job and you have a bully at work every day, you're going to go into fight or flight. Lori says, I'm having 6 bladder installations. I do believe one has helped with the burning. May I ask, what do these actually help the bladder do in the long run? Thank you. Well, Lori, a bladder, so again, it depends upon your phenotype. And there are different types of bladder installations. So we need to know the type of installation they want to do for you. The most common installation is called a rescue. It's a combination of heparin, and heparin coats the bladder, combined with lidocaine to numb the nerves. So the theory behind a rescue is that it just consistently soothes the bladder and turns the nerves off, hoping that over time it calms everything down. The bladder installations are not going to work for pelvic floor. Bladder installations are not going to work for widespread pain. They might give you some symptom relief, but they're not fixing anything fundamentally. Oh boy. All right. Well, listen, my jaw is starting to talk to me. Is there a lidocaine that could last 6 months or more? Well, lidocaine is a short-term numbing agent. Marcaine is a long-term numbing agent, so they could switch it to Marcaine. It's just some people's bodies like lidocaine, some people's bodies like Marcaine, and you won't know it until you try it. But no. Another way that they could turn nerves off for months at a time is with Botox. So the correct answer for that really is going to be Botox. Botox could turn those nerves off for 3 to 4 months. Of course, the challenge with Botox is it might accidentally turn off the nerve, which helps your ability to pee, and so you might have to self-catheterize. But Botox is a viable option for doing that. All right, my friends. You know what? I think we're done. I think my body has said my incisions are starting to hurt. Oh, yes, they are starting to hurt. Sharon said, Botox, others don't work on my face, so would it be the same there? It depends upon where they put the Botox, honey. It just depends upon where they do it. Elena says, "Dear Jill, thank you so very much. I wish you a speedy recovery." Thank you. And you guys, if you find these meetings helpful, please come on over to the IC Network website, go into our shop, and become a member. It would really help me tremendously. It helps keep us going. So, all right. I'm going to say goodbye. I will see you later. Have a great week, and hopefully we'll see you next week. Knock on wood, no fires. And in the meantime, IC Awareness Month, get out and share those daily facts across your social media. And please let people know about these meetings, and please let people know about the IC Network. We're here, we care, we spend a lot of time with patients. Always happy to do it. All you have to do is call. All right, we'll talk to you later. Okay, I'm going to say bye to YouTube first.